Dr. John Onate, and I'm on faculty at UC Davis as a professor of psychiatry and internal medicine. And I am happy today to provide you an overview over the diagnosis of substance use disorders and in both the primary care and mental health settings. So let me go ahead and get the screen sharing started. And hopefully you can see this. And a couple of things. As part of this grant, I hope to continue to produce video series like this for counties, providers, and other people involved in county behavioral health, alcohol and drug services, maybe even primary health, on improving their understanding of substance use disorders and the role of medications in the treatment. And this is a series of 3 lectures that I'm recording. And we're going to start with diagnosis, because oftentimes we have to, first, to be able to give adequate treatment, we need to make sure that we've made the right diagnosis. And even though a lot of our decision-making is based on Gestalt, there's a fair bit of education that we can incorporate into ourselves that can aid us in making the proper diagnosis, and also reducing stigma and making sure that people are getting to the right resources. So I have no financial relationships to disclose. In other lectures, there may be some off-label medication use. It's really difficult to avoid that when you're talking about medication-assisted therapy. Only a few of the medications have an FDA indication for substance use disorder. However, many of them have a tremendous amount of evidence from well-done studies, including meta-analyses, systematic reviews, and there's actually some very good overviews in the Cochrane databases that I really recommend that people go to. I think in addition to lectures like this, it's very important for the listener to know the resources that are available for them to educate themselves and then build on their knowledge base for substance use disorder. So the Cochrane Review, which is basically a wealth of well-done systematic reviews on a variety of medical topics, but they have several on both the diagnosis and treatment of substance use disorders. Of course, PubMed, especially with the clinical queries, is a good resource. And I also recommend the American Psychiatric Association's publication. They have a textbook of substance use disorders that's very, very good. And of course, the DSM IV is excellent as well. So today, for this lecture, we're gonna really talk about the first 2. We're gonna talk about the criteria for substance-related disorders, and we're gonna review how you can screen and different approaches to identifying these patients in the primary care setting or mental health clinic setting. So diagnosis. So there's been a fair bit of change in the DSM-5. So the DSM, the Diagnostic and Statistics Manual, is really a living document. It's basically updated through expert consensus groups and testing, reliability studies, and also updating the diagnostic criteria based on our ever-evolving and improving understanding of the neurophysiology underlying these conditions. And so particularly since DSM IV, in substance related disorders, there's been a fairly significant change in the sort of conception of substance related disorders. So in the past, where there was this clear delineation between people who had an abuse disorder and those who had a dependence disorder, the reality of it is that people seem to cycle in and out of these symptom clusters. And so they consolidated them into general substance use disorders based on particular classes of agents, because they have different effects in the brain and have different clinical syndromes. So you can lump what was formerly called abuse, and and to be honest, it's a challenge, because oftentimes I'll find myself slipping back into this old language. But in general, you can think of the abuse part is, inability to modulate how you use the agent. So you use it to the point where it can cause you physical, emotional, social, economic harm, and yet you continue to use the agent. You can think of it that way. So that's the so-called abuse. And so that's where you may see a lot of our more emergency room type cases, where people are highly intoxicated and they've done X, Y, and Z. They end up being put on a hold or brought into the emergency room or into a holding center in a jail, typically. The other part is the dependence part. And to me, this is the part that's the most chronically debilitating and also the most difficult to treat in many cases. And this is driven primarily by patients really constantly using the medication to avoid the adverse effects of withdrawal and to deal with increasing tolerance to the drug they're using. And so the understanding the concept of withdrawal and tolerance is key in understanding this phase of a substance use disorder. And these are characterized by the need for larger and larger doses of the substance to get the desired effect or intoxication, or using repeated use because of the physical and emotional sequela of withdrawal, which can even be life-threatening. It's also more chronic in the sense that it's hallmarked by repeated failures and attempts to manage or reduce or control their use of the substance, and an obsessive part of it, where a fair amount of their personal time and intellectual capacity is focused on procuring, obtaining the use of the drug, and also, doing things that are they're also psychologically traumatic. The lying, the deception, the self-deception, and deception to friends and family members to try and hide the degree that the drug has taken over their life. And also developmental impact, where you may see people who were doing very well on a drug, moving up the ladder of employment or going to a next stage of education, and falling off the cliff and, basically not progressing, and the drug or the use of the drug being a major factor in that. So I'm going to be going back and forth a little bit in these slides, but I want to talk about alcohol and benzodiazepine withdrawal, because it can be the most serious and life-threatening. The withdrawal syndrome for both alcohol and benzodiazepines are very similar. Essentially, you can interchange them. That clinically, and also in some of my experience, I think people who are dependent on very high doses of benzodiazepines, particularly alprazolam, may have a worse delirium tremens or a more severe clinical course with withdrawal and may be more prone to more seizures. However, I've seen patients with very heavy alcohol use have, equally severe, alcohol withdrawal. So there's a criterion A and a criterion B. A is really the clinical syndrome, and B is the impact of that clinical syndrome. So the clinical syndrome is fairly neurologic and neuroendocrinologic in presentation. So you have autonomic hyperactivity. It's because your glutamate system is revved up and also not controlled because of suppressed GABA activity in the brain. And so you can see sweating, high pulse rate, tachycardia, tremor, insomnia, nausea and vomiting. This can progress to a psychosis or delirium or encephalopathy. So you can see all types of hallucinations. You can have agitation, disorganized verbal and nonverbal behavior, severe anxiety, and then this can progress to almost a catatonic type state in the sense where they can have very severe seizures. They'll need MICU or intensive care support. They may even need ventilator support, and they can die from this. So alcohol and benzodiazepine withdrawal are very serious, and I'll go into the risk factors in a bit. So the criterion B is this: basically these should be so severe that the person seeks medical attention for it. They can't work, they can't function in their family role, and you can't attribute it to another medical condition. So they're not having seizures for brain tumor or some other condition. They're not delirious or psychotic because of schizophrenia or something like that. Sounds easy on paper. In reality, we oftentimes see these situations where it's not really clear where one syndrome is beginning and the other takes off. But that's where it takes a good clinical assessment to understand that. So withdrawal symptoms for alcohol typically happen within 4 to 12 hours of not having access to the agent. This is because these are very short half-lives. And the withdrawal peaks usually within 72 hours. And so this is often, commonly, we really drill this into our psychiatry and internal medicine residents because you really want to identify this very early on, because once that horse is out of the barn and the person has developed delirium tremens, there's not much you can do, and a person can have serious sequelae after event. Including chronic sequelae like developing Wernicke's encephalopathy or Korsakoff syndrome. Usually this is caused by, chronic long-term use of alcohol and repetitive withdrawal and overuse scenarios. Typically after 4 or 5 days, the symptoms drastically improve pretty quickly. But oftentimes people have what I call a chronic withdrawal period. And this can last 3 to 6 months. And so some of that autonomic dysfunction will persist: tachycardia, sweating, insomnia, anxiety, difficulty with focus and attention. And this can drive people back to use. And these symptoms are what we target with medication-assisted therapy. So in general, though, for diagnosing alcohol use disorder, at which withdrawal is one portion of it, you have to understand the other part, which is tolerance. And this is also, tolerance is a key part for identifying pharmaceutical agents that have abuse potential. So tolerance is a scenario where a person can take more and more of the agent, and the side effects and perceived effect of the agent seems to plateau or disappear. And so they need to move up the dosage another step. And And this is a very, you know, this is, you see this a lot in controlled substances. This is why they end up being on controlled substances list. It's, you know, you very rarely see people knocking down the door for hydrochlorothiazide or lithium. However, you do see people really feeling like I need to have more of the, you know, Norco or hydrocodone. Doesn't seem to stop working. Hey doc, can you increase the dose? See this with alprazolam and clonazepam. Hey doc, I'm still feeling really anxious. Can you? I think we need to increase the dose. And so as a you know, physician, nurse practitioner, physician assistant, prescribing these agents, you have to be very mindful that as soon as you go past a few days, and studies show this, that a certain percentage of your population, you may be inadvertently, you know, putting on a pathway for a completely different disorder, or, you know. And so I have these frank discussions with patients because I can't predict it. I've had, you know, 20 plus years of experience as a physician, and I can't predict who's going to develop a problem with these drugs. So, you know, tolerance is really that concept, and identifying tolerance as you evaluate the patient's chart, as you gather your history from the patient. It's important to look for that, you know, at that pattern. So for alcohol use disorder, you know, in order to, you know, meet criteria for a diagnosis, you really want to see at least a 12-month period of difficulties with these agents. So you want to see that alcohol is needed in larger and larger amounts over a longer period of time, or benzodiazepine. So that's a sign of tolerance. And this tolerance can, you know, make it difficult for a person to stop it. And part of the reason why when they stop it, then they start developing withdrawal symptoms. And people don't have insight into it. There's a lot of cognitive dissonance. Part of it, I think, is sociologic. I think it's difficult for people who are prescribed an agent or who have intellectualized the use of a substance in a way that they don't want to admit to themselves that they have a problem, and that the act of cutting back and stopping it, they're actually developing symptoms of withdrawal that they can't tolerate. So cravings is a really strong one too. So people stop, they're able to get through the acute withdrawal period, but now they're in that subacute withdrawal period, and they have a lot of cravings and they have a lot of strong desire. And the problem is, you know, as adults, alcohol is legal. There's no, you know, there's no, you know, outside of, you know, certain situations with a DUI or court mandated treatment, you know, it's difficult to control people's behaviors. They have to have that self-motivation and insight and understanding to stop using. And this is where, you know, adequate both behavioral and talk therapy, but also medication can be really helpful. I'm going to spend a lot of time on alcohol, and then these concepts and patterns actually replicate itself through other drugs. So I'll spend less and less time as this lecture goes on. But, you know, the alcohol use, you know, impacts their ability to fulfill their roles in their family, a job, work, school. And it becomes more and more of this, you know, focus in their life. And so if it seems like the procurement of the substance, whether it's a benzodiazepine or alcohol, seems to dominate their behaviors, even if they have insight or not have insight, but it still appears to dominate. That is an important symptom of an alcohol use disorder. So benzodiazepines is essentially the same. So you can hit pause and spend some time on this slide, but it's, you know, it's essentially the same. So going back to withdrawal, because withdrawal is a key component of a substance use disorder. So there are risk factors for severe alcohol and benzo withdrawal. So the older you get, if you have a past history of it, if you know, the first time a person really has a withdrawal symptoms is extremely severe. You know, having seizures, very, very agitated. They look really, really sick. Comorbid medical surgical illnesses, we actually see this quite a bit for elective surgeries, especially older patients. A classic scenario is somebody coming in from an assisted living situation who needs a hip transplant, and then 2 or 3 days after the surgery, they're agitated, you know, and then start having seizures. And what's happened was this person had an unrecognized alcohol use disorder, or perhaps, you know, when you get their med list from the primary care doctor, they've been taking, you know, 3 to 5 milligrams of or lorazepam a day, and they've been cut off from it inadvertently during the hospitalization, and then they develop a withdrawal symptom. Being dehydrated, electrolyte disturbances. If you have patients who have chronic kidney disease, you have to be aware of that. If they have liver disease like comorbid hep C, you have to think about that. And then if they have any sort of brain lesion or scarring, TBI, brain cancer of some sort, tumor, if they've had you know, a severe encephalopathy that resulted in a lot of scarring in the brain, even as a child, all of this may set them up for severe withdrawal. So moving on to opiates. Again, it's a, you know, you really want to think a long period of abuse. You don't want to label somebody. There's lots of people, probably the vast majority of people who use drugs recreationally don't necessarily develop a substance use disorder. And that's one of the conundrums in this is like, what is it about the, you know, why do some people develop, you know, really severe problems with substances and others can use it for a little bit and walk away from it? It's, you know, it's something that we really don't understand very well, but we need more research in this. So again, you want to think of, you want to get enough history or collateral information so that you can have a good narrative of what's been going on with a person for at least a year when you're trying to assess them for a substance use disorder. So with opiates, again, there's tolerance and withdrawal, and we're going to go into those. Those are important to understand the manifestations of those. And again, it's very similar to what was with alcohol. So they need more and more of the opiates. They've had unsuccessful attempts to self-regulate, and it's having a major impact in their functioning, both socially, in their families, at work, psychologically, and the procuring or getting the agent or the drug itself has become a massive part of their life. Not a big fan of movies as examples for psychiatric conditions, but I do think the movie Trainspotting is probably one of the most accurate depictions of the impact of opiate uses in it. So while we're all on shutdown during the coronavirus pandemic, that might be something to look on Netflix or look it up on a streaming service and watch that. So opioid withdrawal, it's very, very important to understand opiate withdrawal. Because especially if you're going to be involved in dispensing buprenorphine or Suboxone or Subutex, you know, you want to have a good understanding of identifying when someone is in withdrawal and rating that. The good news is it's fairly simple. You can train a nurse to do this very easily. Even a very high functioning MA or psych assistant could help do this. With supervision from a psychiatrist or nurse practitioner or physician assistant who's been well trained. But essentially, just like alcohol, you know, they develop a clinical syndrome when they stop having access to the agent. And again, the half-life bears an impact on how long and when these symptoms start happening. So on the short end, fentanyl, which has extremely short half-life, they start having symptoms within a few hours of not having access to it. Heroin, somewhat the same. Hydrocodone, Norco, somewhat the same. On the other end of the spectrum, you have methadone, which has an extremely long half-life of, you know, And part of the reason methadone has such a long half-life is it also is lipophilic and starts accumulating in your fat cells. So even when you stop taking it, you start leaching it out, and it prolongs the detox period for some people significantly by weeks sometimes. But the clinical syndrome is very, once you've seen it a few times, you immediately start recognizing it. It's, one, they feel horrible physically and emotionally. So they look depressed. They look like they have maybe like a horrible flu. They may be having snot maybe coming out of their nose. They ache all over. They're nauseated. They're vomiting. They start having diarrhea. They can make a huge mess, and it can be very stigmatizing and shame inducing for a patient, and it can also induce, you have to be mindful of your own countertransference, because if you see enough of this, it can be hard to be empathetic with somebody when they're at state, but they're very miserable. You see pupillary dilatation, which is classic. The other classic thing is so-called goose flesh or piloerection. So they start having, goosebumps, sweat a lot, they can't sleep, they feel horrible. Typically it lasts a few hours to days. It depends on the half-life of the agent they're using. It's not fatal in and by itself, but in combination with like alcohol, benzo withdrawal, which oftentimes these people are using multiple drugs. If the person is talking a lot about heroin and maybe they forget, or you don't realize that they're also withdrawing from alcohol. I have heard of cases, unfortunately, where people have died from delirium tremens because everyone was focused on their opiate withdrawal. So you want to, be mindful that they could be withdrawing from multiple agents. This is the sort of rehashing what I just said. Be careful, realize that methadone may take a lot longer. Also, there's a trend for methadone clinics to really push the doses sometimes. So people may have these withdrawal symptoms even though they're still taking methadone. I've seen this quite a few times of trying to transition patients from buprenorphine to from trying to switch patients from methadone to buprenorphine, for example. So you have to lower the dose. And even a 20 to 40 milligram drop in the dose, for some people, they may have some withdrawal symptoms. And so a lot of times I'll pre-treat them or give them some clonidine and some antidiarrheal medication, because they may experience some of that. And you wanna treat the withdrawal symptom, because if you treat the symptoms of the withdrawal, you're going to really help the person get through this process. And that's really the whole goal in treating withdrawal, is to reduce its, the negative impact of it, how miserable it is, so that the person won't go back to using. Stimulant use disorder. So again, it's, kind of a similar idea. You want to think about, they've clearly had months to years of problems, stopping the agent, needing more and more of it. You don't have to have all of these criteria. You only need 2. And you also have to show signs of tolerance and withdrawal of it. And you can see this with prescribed amphetamines. This is where, I think the use of, especially the long-term use of stimulants in adults for attention problems, to me, is somewhat controversial, and you really have to be mindful of trading one disease state for another, particularly if the person involved has no symptoms of ADHD as an adolescent or child. You have to be very, very careful in those cases. But the withdrawal in methamphetamine and amphetamine is basically they sleep a lot. I mean, if you've seen this in the emergency room, these are the patients, like, they come in like super agitated. They're essentially intoxicated on methamphetamine. They get some antipsychotics. They get put in a posy. they get placed on a hold. You hydrate the heck out of them, and then eventually they'll calm down, and then they'll sleep for hours, maybe even days. So fatigue is like the most common side effect of symptom of withdrawal. They can have pretty vivid, unpleasant dreams. Then they can start developing some, intermittent like insomnia and hypersomnia. This can go for a while. Their appetite increases. That can also be for weeks, months after stopping amphetamines, because amphetamine is a very powerful appetite suppressant. In fact, it was, one of the reasons it was used and developed was to reduce caloric consumption. It was used as a diet pill. It was also used by the Japanese to reduce for their soldiers, so they would eat less rice during the war. And then you can also have a lot of, passive behavioral changes where the person can be very slow to respond, or they can have intermittent periods of agitation. And this can take quite a while for them to get through. Sometimes it can trigger, it can be that second hit that can cause somebody to have their first break psychotic symptom as well. Marijuana. So cannabis, also you can have a use disorder with it. I think there's still some misconception out there that you can't become addicted, so to speak, to cannabis, but the research really shows that there is a subset of people who are susceptible to becoming, to having a cannabis use disorder. It can definitely display tolerance like other drugs of abuse, and there is a distinct withdrawal syndrome with marijuana. You also have to be careful with marijuana because sometimes this doesn't show up in drug screens. There's tetrahydrocannabinol, there's some synthetic cannabis, there's K2 and spice. These can, sometimes you may not catch these. But withdrawal symptoms, similar to other agents is, if they have an abrupt cessation or they don't tolerate down. And again, it's very difficult to know who these people are. But they develop irritability, anger, aggression, anxiety, depressed mood. So it can look a little bit like opiate withdrawal, but you don't have all of those physical symptoms with it. So, again, it's not as, it's milder. So it's unusual or rare for people to present in particular for treatment for it. But it's something to be aware of, particularly if you're detoxing them for another agent and they've been using quite a bit of marijuana. That can be can complicate the treatment plan, or if someone's hospitalized or held for some other reason. So screening and identifying substance use in primary care. This is, and I came up with this lecture series, looking at the primary care setting. That's where I work, but this is very applicable to any community mental health clinic or urgent psychiatric clinic as well. So a good rule of thumb is to screen everyone and to repeat screening periodically if you're doing ongoing care. One of the things I teach my residents and really have to remind myself, if you run into a snag in a patient's treatment plan. So let's say you've been treating someone for a number of years for depression, and they've been stable on a combination of medications and psychotherapy. And then they seem to fall off the cliff a little bit and have a relapse, and you can't, don't really understand why. Don't immediately assume that it's a medication failure. It could be that they've developed a problem with a substance. And so it's good to step back and do a reassessment, not just for substance use, but the whole thing, to kind of step back and reassess your diagnostic schema for that patient, which includes screening them for new onset substance-related issues. There is screening instruments you can use, the Audit C, the KHD. And so these are listed here on the slide. I think what's important is being familiar with it, train your staff, and be consistent in using it. Here's the example of the audit C. I prefer single item screening questions because I work in a pretty busy primary care setting, or I'm on call and we're covering the emergency room. And there's data though that shows that sometimes these single item questionnaire, single question items can be just as effective in kind of opening up, especially if you're using the motivational interviewing approach, open up the, the door, a sense, with the patient to help them get assessed, treatment if they have an underlying substance use issue. So, a good one to think about is like, how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? It's very non-judgmental, leaves it open for the patient to kind of fill in the blanks. And then it's like using good motivational techniques of, affirming the patient, if they disclose to you, affirming their views, and also taking time to restate and clarify what the patient is telling you so that you understand what the role of the substance is in their lives and where they are on the continuum for change. So I'm going to end this here. We have a whole section lecture series on alcohol and withdrawal. Please send Deborah or contact me if you have any questions. And I'm going to put together, if we get enough questions, I'll put together a video response similar to this to address those. Have a good day and be safe.